All right. Everybody ready for an exciting hour? I know it's been a very busy day, lots of learning. We've got a little bit more. This is going to be a very, very interactive session. So we are going to be talking about data and decisions in advanced non-small cell lung cancer, addressing open questions to optimize immunotherapy and targeted options. All right, so for those of you who don't know me, I am Heather Wakelee from Stanford University. I'm going to let my co-speakers introduce themselves quickly.
Thank you guys for sticking around. I'm Helena Yu. I'm a thoracic med-onc at MSK in New York.
Hi, I'm Behl. I'm a medical oncologist at the Mayo Clinic in Rochester, Minnesota.
Great. Okay, so I want to first of all thank PeerView for providing this session, AstraZeneca for providing the educational grant for this symposium. I want to make sure you guys are all aware there is going to be a lot of polling during the presentation. You get to submit any questions. We're going to do our best to answer as many as we can during the multiple Q&A segments. For those of you in the room, you will want to use your personal device, aka phone. To scan the QR code I will be showing you in just a second, and use them to respond and also to submit questions. For those of you who are joining us virtually, please respond to polls on your screen, and enter questions into the chat window. All right, so this is the promised QR code. I'm going to pause. I'm going to watch for everyone's phone to come up and to scan the QR code. All right. That's right, I'm looking at you. Had not scanned that yet. Okay, go ahead. All right, thank you all. It's also on the table if you didn't get a chance here. Okay, and you can also visit peerview.com/lungcancer26. Slides and practice aids can be accessed that way. Okay, so what are our goals during this presentation? Our goal is to, first of all, stay awake and engaged, since we've been doing this now for 12 hours for those of us in Huntington Beach. All right. We are going to work on how do we improve biomarker testing and non-small cell in a real-world setting. Which factors should we be thinking about to guide first-line selection of immunotherapies and combinations in non-small cell? And how to individualize the selection and use of EGFR-targeted therapies in first-line metastatic non-small cell. So we're taken from a few different really important buckets when we think about who are the patients that we see and how can we best help them. Okay, and this has town halls in it where we want you guys to be engaged. So before we start each session, we will have a town hall session where we have some questions that we'll show that have come in from audience. That'll be updated as you guys send in other questions. We'll talk about them amongst the faculty, invite the audience to participate a little bit as well. And again, you can keep asking questions. If yours doesn't show up, we will come back to some more at the end. And with that, I'm going to sit down for a moment and have Dr. Behl come up.
Thank you, Heather, and thank you everyone for staying so late. So this is a topic very close to my heart. I practiced for 15 years in the community, and this is maybe not a big challenge in the academic setting, but it is a challenge out in the community. So let's start with the question. Please use your QR codes. In your opinion, which of the following represent top challenges related to biomarker testing in advanced or metastatic non-small cell lung cancer?
This is good keep you awake music.
Okay, so it looks like answer is still coming in. Okay, I think that's it. So it looks like some people chose obtaining adequate tissue for comprehensive biomarker testing, certainly a challenge, long turnaround times, limited access to comprehensive testing, uncertainty about how and when to use different testing approaches, results, how to interpret them, and how to apply what we get on the result, cost and reimbursement, and all of the above. So most 47%, almost half the people say all of the above, which I think is also my opinion. Heather, what do you think?
Yeah, I think that this is really, brings up all of the challenges we still face. ISLC has made a big effort to sort of try to understand what we can do to increase biomarker testing, working with a lot of partners from different companies and advocacy groups, and it still remains a big issue. I think we have made it easier to be able to get reimbursed for testing earlier when a patient's been hospitalized. That's a big win, but I've been talking to several different community groups, and they still, it's trying to get the coordination of, especially if you have multiple different hospitals and different private practice groups, trying to get agreement on what test you're going to order and getting the pathologist to willing to do it. It's just really, really challenging. And then we still have to wait. Even with the fastest test, it can be a week or two, which but for a patient with newly diagnosed disease, that's a really, really long time. Answering with other things, I think that I like to think about liquid biopsy for any patient with newly diagnosed metastatic disease, just to make sure we've got 2 opportunities to get an answer, and that often comes in faster.
Yeah, 2 hits on goal, definitely. I think, and also, once we get the results, then it's acting upon it too, right? So I think like the whole spectrum is really important, and I think in the community, it's still a big issue for sure.
Yeah, so I think that, the basics are always the most important and the most impactful at a population level. It's great that we have a whole meeting where we talk about newer therapies, but basic things like smoking cessation, biomarker testing, if we can make these optimized, we can have such a big impact on lung cancer. And biomarker testing for one patient, so at the population level, of course, very important, but at the patient level, missing one patient who has something targetable is missing one too many, because there goes our chance for living longer with better quality of life. So this is something that absolutely needs utmost attention, and we need to solve these challenges. So let's get to some questions that have been submitted by the audience. So let's take on the first question. What strategies can minimize delays in test turnaround times and ensure that results are available before we make treatment decisions? So Helena, maybe I'll call on you.
Sure. I think that to the degree possible, reflex testing, right? So I think rather than waiting for a provider to order the testing, if there's a biopsy suspicious for lung cancer, that testing would be reflexed. And then I think engaging the people who do the biopsy, so interventional radiology, surgery, to educate them, and really, so by the time that us as medical oncologists see the patient, hopefully, a week or 2 later, we have that data at hand and we can act upon it immediately.
Heather, anything you would like to add?
No, I think that reflex testing, that education to the primary care doctors, to the pulmonologists, to everybody who's going to see the patients before we do, that we're going to be able to best do our job with that information. And so if they can get it ordered quickly, right, and just making that easier, getting the pathologist to sort of almost like an opt-out of doing the testing,
Yeah. So Heather, you kind of spoke about this a little bit, but when and how should we use liquid biopsy, especially in the community practice?
I really think the only true barrier right now is potentially going to be reimbursements. But I think from a practical standpoint, from the better quality care, being able to get those answers faster, I really think everybody should get that at point of diagnosis.
Helena, what do you think?
Yeah, no, I think that again, should be, if not sent before we meet the patient, then of course at the time, and of course at initial diagnosis, and then for patients on targeted therapy, I think at a minimum at the time of resistance, it would be good to send off liquid biopsy, and then of course tissue biopsy if we can.
Okay. And then another question we have received is, how do we stay current with rapidly expanding biomarker panels and guideline updates in a busy oncology practice where presumably, or actually, really, the physicians are not typically focusing on one cancer type, they are seeing many. So it is a profound challenge to keep up with all the tumor types, all the new things that come up. Helena, what guidance, what advice would you offer?
This is hard. I mean, even focusing on lung cancer, I mean, there's, thankfully, there's new data kind of coming at a very rapid pace. I think it's programs like this, right, in terms of CMEs. I think ISLC and ASCO, AACR, they all have, sort of good treatment guidelines. that are also important. But and then having a network of sort of colleagues that you can trust, or sort of tumor boards or other avenues to be able to ask other people. And we do that all the time, right? All of us ask for help. So.
Heather, what are your thoughts?
I think it just, you can't learn it all. I remember being in medical school during the era where we went from memorizing it all to everything's open book, because you cannot possibly know all of it, but you need to know how to process it, right? And so people need to have that mindset of, where do I go to make sure, well, first of all, I know I need to test and I need to do comprehensive. And then when I get a result back, we need to be working on uniform kind of reporting standards so people know what they're looking at when they get those results back. And then to be able to know, how do I figure out what to do with this result where, boom, this one's positive, most of them maybe aren't. And that's where the guidelines come in helpful, or having like a molecular tumor board or access to it, being able to zoom in or whatever your platform is to be able to do that. I think that's really critical.
Yeah, and I'll just add, because I was in the community, it was super helpful to me to have academic friends that I could turn to and just say that, I have this weird report back, what do you advise I should do with it? So I think having those academia to community bridges is very important. So let's get to just a little bit of data. Not that I think anyone needs convincing, but we know from the My Lung Pragmatic Study, this was, the time frame here is 2020 to 2022, which is not all that long ago. So gaps in biomarker testing in the real world community practice were looked at. And we see that, if you look at individual testing, then PD-L1, sure, 84.2% were getting PD-L1 testing. EGFR was also being done. But really, this is very suboptimal in this age. We cannot be sequentially using up our tissue, testing one thing, then testing the next. We need NGS testing. And if you look at the, the foot of that slide, advanced non-small cell cohort in this pragmatic study, a large proportion did not receive comprehensive biomarker testing. 54.6% of patients received biomarker testing prior to first-line treatment, but that's like 46% that's nearly half not getting the testing they should have got. And if we look at why was this testing not being done, was it not available? But that's not the whole story. The number of patients, the barriers to testing, if we look at the advanced cohort on the far right side of the slide, we find that some of it was, sample tissue retrieval, but also another factor was attitudes and perceptions. Other reasons is a big 60%, which means that this is probably a very individual challenge to individual practices. So we really have to look at, the individualized approach to what is each practice challenged with and how can we help. So there is not going to be one size fit all. So this is, just to point out, this is 2020 to 2022 time frame. Now looking at the 2024 ISLC Global Survey, things improve in this time span. We see that 67% now say that it's very important to get testing. But then look at the far right side, that's 43%. Sometimes or often will treat patients prior to receiving the biomarker testing. So that is still a huge percentage. Certainly improvement, but not quite enough. And if we look at the key solutions that were identified, then those are very much the things we already talked about. So proper biomarker testing matters. The key principles, comprehensive biomarker testing prior to therapy is essential to optimize care, because I'll repeat myself, but I think it's just so important that missing one patient with a biomarker, with an actionable mutation is missing one too many. That is a difference of living longer and quality of life to that patient, and that is irreparable harm. We cannot afford to miss these mutations. So we have to test for all targetable genomic alterations, including PD-L1. NGS and IHC are both important. Now we have a new drug, Telisovir, which has gained approval. MET IHC testing has also become important, but not typically on the radar of many community practices. So we need to reinforce that testing is important and different kinds of testing is important. Heather and Helena both made this point that tissue-based and liquid biopsies both are important. They help to capture as many mutations as we can when we use them concurrently. And NCCN endorses that stand. So when I was in a community practice, not that long ago, in fact, reimbursement was not a challenge. I don't remember a single time that some insurance company said, why did you order both? So fortunately, that's not a challenge. NCCN agrees that this is very reasonable to do. So I think we should be doing that. And of course, the accurate interpretation and application of test results is essential, but certainly challenging. So to address that gap, there are efforts to develop more provider-friendly biomarker reports. So this was a consensus for a more provider-friendly next-gen sequencing molecular biomarker report developed by the College of American Pathologists and Molecular Pathology, and ASCO also endorses this. So basically, they prioritize putting the actionable mutation first, and unambiguously, the report is supposed to say, first of all, patient name, simple things like that, and what is being tested. Is it tissue? Is it blood? And then clearly, first of all, say, found X, this is actionable. And also equally clearly say that, this is a variant of unknown significance, and we don't know that it is actionable. So make it as reader-friendly as possible. So, we can certainly look at more questions that have come in. But another important point to touch on is the role of multidisciplinary teams or molecular tumor boards. Like, what role can they play in the community setting, and how can we access them efficiently? Helena, what do you think about that?
Yeah, I think that there are obviously sort of online multidisciplinary or molecular tumor boards. At smaller community hospitals, that becomes more challenging. I think, as you said, having, especially in thoracic oncology, I think there's like a really collegial feeling where, I think if any of us would be happy to discuss any reports with, people that reach out to us too. But yeah, I don't know if Heather, you have other thoughts.
No, I think that having that sort of a broader molecular tumor board accessibility is really important. You don't necessarily need the whole tumor board, but just sort of a interactive way of being able to, we have this, have patient, their tumor has this mutation, what could I do? And have like a way to kind of send that in if you don't have academic folks that you can talk to. We have our monthly tumor board, but obviously once a month isn't enough. And so we then have those establishments to talk, establish relationships with the pathologists to be able to talk about it. And then the phone a friend network, which we have as the academic world, but for the community, being able to tap into that, as you had mentioned.
Yeah, no, I agree. Phone a friend is a very important strategy here. So there's a very thoughtful question, and I don't know the answer, so I'll call on my expert friends. A question from the audience is, how do we advocate to Medicare to reimburse NGS testing for biopsies done in inpatient?
I think we advocate together, right, as the communities. I don't know that there's any one person can do that necessarily, other than to show the NCCN guidelines and, focus on that, so. But it's gonna require a bigger change, probably.
And I see Dr. Kelly in the audience, so if we can have her help to make a lot of noise. And
Yes, I think we are working on it. We know Longevity's working on it as well, so it is on our radar screen. Sorry. So it is on our radar screen as well, and Longevity also has a really high priority interest in this. And there is I think a summit next week on biomarker testing, and typically there is somebody there from CMS that does speak and does give us new information, so we'll be looking forward to that too. So I do think that 14-day rule, from what I know, we just think, no, you cannot do it, but that's actually not true. But I don't think we understand the 14-day rule as well as, of course, those that are working on it every day. So there are some nuances to that, but we just know that we can't order it. And it may not be the CMS, it may be your hospital pathology department that, again, they have to pay for that inpatient NGS. So it gets billed to their department. So I think understanding that whole process better of the 14-day rule, then we can start finding solutions and advocating and tackling it.
Thank you, Dr. Kelly. There is another question, but I'm not sure if we have time.
Yeah, maybe. No, go ahead.
Okay. So another question is how to confidently interpret and act on variant allele frequency subclonal mutations, or low confidence calls in NGS reports, especially when results conflict with clinical presentation or prior testing?
That's a hard one. I think that's when you really need to have a more nuanced conversation with people. But not everything that is seen is necessarily something you need to act upon. And it's really, you're going to go with what you believe is true from the report first. Those other things can kind of float around once resistance develops potentially for further conversation, but a lot of it really isn't actionable.
And I think having that structured molecular report where this happens all the time, it's like, is this a HER2 mutation? Is it an insertion or a RET like point mutation versus a fusion? So I think if we have, the data, kind of proven oncogene drivers and then those variants of unknown significance lower, it's confusing for all of us.
Yeah. I agree. This will have to be case by case. And okay, and with that, let's go to the next question, and then I'll hand over to Heather. So if the audience could take a minute and think about this and answer, please. In your opinion, which of the following represent key challenges related to integration and use of immunotherapies and EGFR-targeted therapies in the first-line setting for advanced and metastatic non-small cell lung cancer?
Okay, you guys got to think for a long time about that one. Okay, all of the above seems to be the answer. So keeping up with and understanding the evidence, determining the best treatment for each patient, looking at all of the issues around the different populations, and balancing benefits and risks of the different therapeutic options. Okay, great. And now we're going to talk about immune therapy. We're going to do this quickly. Many of you have seen a lot of this data before. But before we jump into that, we just have a few key questions that we know kind of go into people's minds. And so we're going to talk about this as a panel. And I'm going to kind of lump a couple of those together. But the one I'm going to just answer is the value of the CTLA-4 in PD-1, PDL, adding that to PD-1, PDL-1 inhibition. When do you think about that in first line, Helena?
Yeah, this is tough, and I really think providers do really different things. I think that combining that with the other question, I think the things that make me think of using both CTLA-4 and PD-1, PDL-1 are co-mutations like STK11 or KEAP1, patients that are PD-L1 0%. Those would be people. I'm going to admit that I don't do it a whole lot, but that would be the population where I'd say that would be someone that I'd want to intensify.
Okay. Anything you want to add?
Yeah, no, I agree that those are the situations, and sometimes low PD-L1 and squamous also makes me lean towards combination.
Okay. Now we're going to have audience participation. Who actually does testing for STK11 and KEAP1?
Who has that back by the time we make our treatment decisions? That's the other.
Yeah, not always. Okay. All right. Maybe we should have people stand up to answer next time, so we're moving. All right. And then the big question. We're not actually going to talk about this as much today, but it is the big controversy. This was all over social media, for those of you who missed it, as well as there was a little buzz around ASCO, and then when it got published, even more. Does the timing of immune therapy administration, does that matter in your opinion? And whether or not it matters, can you do anything about it within your healthcare system? Deepti.
It was very provocative. It's like really sort of makes you sit up that this would be a factor. But like you said, it's controversial, so I'd like to let the dust settle and see, is this really true? In terms of if it is true and if we are going to try and treat everyone in the morning, it's going to be a huge challenge.
Yeah.
I think, but just to say that if those were curves of an active treatment, we would be jumping on that. I mean, an OS benefit that was that significant. And I think it was before 3 p.m., right? So it's not like it has to be 8 to 10. So to the degree that's possible, I think you can say, if available, schedule early. I think it was pretty compelling.
So probably in my healthcare system, there's a huge focus on the decoupling, so having the treatment not on the same day as the patient is seen, just because that improves efficiencies of people actually showing up when people think they're going to show up and not after the doctor has been running an hour and a half behind and finally gets people upstairs. So maybe that will be an argument for it, but yeah, I think it is going to be a little bit challenging.
I'll just add that in the community, the single-agent immunotherapy was intentionally scheduled for later in the day because to wrap up on time, these were the easier infusions. So it would be quite a sea change if we had to.
Okay. But probably worth trying to see what we can do, right? Okay, great. Now, we have a very busy slide, which I'm not going to read to you, but it's just the timeline of when our different immune therapies and combination regimens came into being and were approved. So you can take a photo of that and read it at your leisure. Okay, but I'm going to talk about a few of kind of the key studies. So first of all, in the patient population where the tumors have high PD-L1 expression, this is the world where we think about single-agent immune checkpoint inhibitors with PD-1 or PD-L1 agents, pembrolizumab, atezolizumab, and cemiplimab, where we have the best data, with median overall survivals approaching 2 years in all of these, response rates in that 40% range. Think about our other things where we have like a biomarker, and when we have it and we give it treatment, we look for responses maybe even higher than that. So we know that PD-L1 is an imperfect biomarker. It's good, but it's not perfect. However, when it's there at a high level, especially the higher you go, the more likely, good response, good single-agent data, some long-term survivors. And so this median doesn't tell the whole story. We all know that there's that 15 to 20% of patients living 5 years plus, right? And so this is really exciting. When the FDA did this pooled analysis trying to figure out, should we add chemo or do we not need to add chemo when we've got that high PD-L1 expression, wasn't really great at answering the question. Maybe no difference. Some of the analyses, PFS favored combination. I think from a clinical standpoint, most of us are thinking about it where if this is a patient that we're worried is going to fall off the cliff, meaning if they don't have a response right now, they maybe don't have another chance. Those with high disease burden, especially something else going on, those are the ones we tend to think about giving chemotherapy to because we know that there is a population where single agent isn't going to work. That's that 50 to 60%, right? By adding in the chemo, you increase response rate, increase progression-free survival, but maybe don't change that 15 to 20% who are the long-term ones who benefit. That's where that overall survival curve is really pulled forward, right? You guys have anything you want to add to that? Anybody in the audience have anything they want to add to that? Okay, keeping on. I somehow didn't click that very well. There we go. The IO-IO combinations. Now, from the back of the room, I want everybody to read through all of those different subpopulations. Okay, just kidding. I know you can't read that. What this is showing, this is combination of immune therapy, right? So bringing our CTLA-4 along with PD-1 inhibition. In this case, it's with nivolumab and ipilimumab versus chemotherapy. We'll have a few others where we're combining in the CTLA-4 agent. Here we're seeing that in this trial, this was the Checkmate 227 study. That's the one that we're showing here. This was looking at combination checkpoint inhibitors versus chemotherapy versus single-agent checkpoint inhibitor, showing that the combination was actually better when we looked at overall survival. And that seemed to be true in almost every one of the subsets, except particularly maybe those without a smoking history where we're bringing in some of our driver mutations, okay? So important. We've got two other approaches. So this was the combination checkpoint inhibitor versus chemo. Then we've got the Checkmate 9LA, which is a little bit of chemo, plus the checkpoint inhibitor, right? And then we've got the Poseidon regimen, which is a little bit less CTLA-4, maybe a little bit more chemotherapy. And let's look through the data as we go through. All right, so here's the 227. Now we've got 6-year long-term benefit, where we are seeing that in that group of patients getting the combination of nivo and ipi, nivolumab, ipilimumab, we've got that tail on the curve of around 20%. With nivolumab alone, there's still a little tail, but it's less, maybe 15%, and chemo alone, even less, remembering that some of those patients probably got checkpoint inhibitors later line, okay? And what's really intriguing here, and we've already alluded to it in our town hall conversation, is that that benefit was seen even in patients without PD-L1 expression in their tumors. And that's sort of one of the things with CTLA-4 theory, brings up that PD-L1 expression, so there's that synergy, especially when you don't have the PD-L1 expression, maybe not as critical when you do, but that's kind of debated a little bit. Okay, so you can see here the benefit with and without PD-L1 expression, maybe a little bit more separation in the group without, where that CTLA-4 benefit is perhaps more. Okay, this is 9LA. 2 cycles of chemo plus nivolumab ipilimumab versus chemotherapy. Striking difference in those without PD-L1 expression, or with PD-L1, we're looking at overall survival in both of these curves. And then with Poseidon. This is, again, combination CTLA-4, checkpoint inhibitor, PD-1, with chemo versus chemotherapy. And again, we see this nice separation. What we're showing is sort of an all-comers, and then in that very busy plot that you see there, forest plot, we can see that with PD-L1 expression, higher PD-L1 did seem to have more benefit, lower, maybe less, but it's not a clear story there either. So kind of the take-home that you heard from many of us is this idea that, well, if my patient doesn't have PD-L1 expression in their tumor, that's one where I'm going to lean more towards adding in the CTLA-4. Okay. And then the molecular subsets question. So for those of you who were at the TTLC conference today, there were some beautiful discussions around this. It does remain a little bit confusing. What this is showing, those curves at the top, is actually from an MD Anderson single institution retrospective review of their patients, looking at the patients with STK11 and those with KEAP1, with or without those, and showing that for patients that had STK11 or had KEAP1, they didn't do very well with immune therapy, and if they didn't, they did much better. We also have some data from Keynote 189, and so this got everybody thinking, and especially in the setting where there's KRAS, but this was without that, that if you had these mutations, checkpoint inhibitors just were not working very well. But then when we look at some of the trials that combine CTLA-4 with the PD-1 or PD-L1 agents, we see that it didn't seem to matter as much. So in the STK11 either mutation or wild type, we see actually benefit when you bring in the combination CTLA-4 and PD-1 inhibitor. So that was exciting. And then in Poseidon, similar trends are seen also with different combination, in this case with dabrafenib and tremelimumab. So, sorry, I'm misspeaking. It's been a very long day. Okay. So with durvalumab and tremelimumab, that is what I meant to say. Thank you. Okay. So that's sort of this data around this concept of when should we be bringing in CTLA-4 in addition to our single agent PD-1 or PD-L1 checkpoint inhibitor. We know we bring in some more side effects when we do that, and that's why I'm talking about side effects here. When is it worth it? And it seems maybe it's worth it more when you don't have PD-L1 expression. Maybe it's worth it more when you have STK11 or KEAP1 mutations. I don't know that we've absolutely 100% proven those things. However, we've really given a lot of data that's been consistent across trials in favor of that approach, which is why you're hearing it in our personal practices. Okay, now this is showing immune-related adverse events. We never want to talk about checkpoint inhibitors and not talk about these. I'm only giving you one slide in light of we've got a lot to cover in this hour. So things when we think about risk factors, it's a little hard to know. We don't always know who is going to have immune-related adverse event. We still have to have that mindset. It could be anybody. I always warn my patients, if you get anything new, let us know, because we need to make sure. And we know to do testing to make sure we're not missing an endocrinopathy. We know to make patients let us know if you're having any change in your bowels, if you're having any increase in your decreasing respiratory status, chest pains, any of those sorts of things, confusion that the family's noticing, let us know so we can make sure and evaluate it and rule out that it's immune-related adverse event. And then there are a lot of different beautiful guidelines on how to manage that, but it's usually think about it quickly, think about steroids quickly, bring in your subspecialist when you have that opportunity. Okay, now we get to answer another question. All right. Outside of a clinical trial, what first-line treatment would you recommend for a 68-year-old man? He used to smoke. He's got adenocarcinoma. He's got a lot of bulky disease in his liver. He's got a lot of bone metastases. He has no PD-L1 expression in his tumor, has a KRAS G12C, and an STK11 mutation, okay? So would you give an immune checkpoint inhibitor monotherapy with chemotherapy, dual checkpoint inhibitor, so bringing in your CTLA4 without chemo, or dual with chemo, or a KRAS G12C inhibitor, or not sure? This is when you bring out your personal device and use it to vote. Thank you. Maybe we'll get music, people can dance. Okay, when you're done voting, everybody can stand up and dance a little? No? Okay. Okay, all right, most people voted for a dual immune checkpoint inhibitor with chemotherapy. Helena, how would you vote?
Yeah, this is exactly the patient, right? You
Yeah.
didn't say fitness, but I think if pretty fit, I'd discuss ICI with chemo or dual ICI with chemo. But this would be someone that I'd probably do the ICI chemo, 9LA or Poseidon.
Deepti?
Yeah, I agree.
Okay. Yeah, I probably would too. I mean, we did sort of tee it up for you because we're putting in the things where there's a little bit more data, no PD-L1 expression, as well as that STK11 in a reasonably fit person. Okay. So now let's actually go to a case where this is a patient who's Rohan, who is our 68-year-old gentleman. He presented with hemoptysis. He had been having some worsening cough for the last couple years, but he didn't really think much of it, thought maybe it was reflux. He used to smoke. CT of his chest shows that he has a mass in his left lower lobe. He's got some lymph nodes, and unfortunately also has a pleural effusion all on the left side. So not a lot of disease, right? But there's some. And it does look like it's metastatic with that effusion. He's got pulmonary, past medical history, a little hypertension, a little hyperlipidemia, nothing terrible. He has a liquid biopsy, no ctDNA is detected. He has a bronchoscopy for a biopsy. The mass is confirmed to be lung adenocarcinoma. It's poorly differentiated. Biomarker testing is done. His PD-L1's 20%. He has mutation analysis and has a KRAS G12C. So what would you think about for this patient? You don't get to vote here. You actually have to talk. So anybody want to say anything before I call on our panelists again? Is everybody still awake? Okay, I'm not seeing anyone nodding off, just maybe look at other phones. But okay, Deepti, what would you do?
Yeah, I would choose the Keynote 189 chemo plus Pembro regimen. I think pretty standard PD-L1 20%. Sounds like a healthy, otherwise healthy person.
Okay.
Same.
Yeah.
This is like our standard classic patient, right?
Right.
So.
Okay. So relatively low disease burden, has some PD-L1 expression, has just a KRAS G12C, which we know can be sensitive to immune therapy. I think that's perfectly reasonable. So single agent checkpoint inhibitor, chemotherapy. Anybody in the audience, different opinion? No? Okay. Well, what if the same patient actually has bulky liver metastases, a lot of bone metastases, and has his STK11 and PD-L1's 0? Okay, we did kind of vote on this exact case a minute ago. Anybody have a different opinion from the last time we voted on this case? No? Okay. So this is where we think about bringing in the CTLA4. All right. And now you get to vote again, taking out your phone, using that arm. Okay. Before we move on, please answer this question. We're not going to show the results, but this is just to get you thinking about first-line immune therapy. Okay. And then we have a few questions that we can talk about. Did you guys finish scanning your code? Okay, good. So now we are going to talk about a couple questions that I have gotten from our audience. So without head-to-head trials, how do we pick first line what to do?
How do we pick?
What do you do first line?
So, in the community perspective, I can tell you that you don't pick. There are pathways. So how a combination or a particular drug gets on the pathway is either it's first or it's fabulous or it's, F, as they say. So if it's on the pathway, then that's how the practice will function. But if there's no pathway, then, and if you're asking, then I think it defaults to what an oncologist is more used to, more familiar with. If I was picking between Poseidon and Checkmate 9LA, I'm likely to pick 9LA just because it's the more familiar regimen to me. But of course, this becomes just individual preference.
Yep. Yeah, because I think Poseidon would be, he's not setting 2.
Yeah, and I've heard in the community, like, yeah, because Poseidon
Yeah.
is approved in other different tumors,
Yeah.
I think, it's whatever people feel comfortable with.
Yeah, good. Okay, we do have a few other questions, but I think in the interest of time, because we do want to be able to talk about EGFR, we will shift over to you, and then we can come back to some of these other immune therapy questions if we have time afterwards. So.
Okay. All right, so we will quickly, just like we blew through immunotherapy, we'll do the same for EGFR mutant lung cancer. There's been a lot of progress in the last couple of years. So first, a few questions. So first, with OS now confirmed for both FLAURA2, which is osimertinib and chemotherapy, and MARIPOSA, which is amivantamab and lazertinib, should combination therapy become the default first-line approach for most patients, or is osimertinib monotherapy still appropriate for select low-risk cases? Is anyone, I guess maybe I would say, who is not using combinations up front, if people would raise their hand? Is anyone still giving osimertinib as first-line treatment? Luckily, the lights are blinding me, so I can't really see. Heather, tell me,
I
yeah.
still have a couple. Well, I have patients who we started before all of the data came forward. And then I've had patients who had very minimal disease burden, who were older, really didn't want to go into something systemic, where I felt comfortable doing that. I've also had others who've argued not to, but had a higher disease burden where I was a little bit firmer on going with combination.
Yeah, I think exactly like you said, it's opt out of. So I think there's the default, but if obviously we take into consideration what our patients want and their specific situation. What about you, Deepti? Do you?
Yeah, no, I agree. The default is combination, but of course, case by case, you can still just think about it.
And I guess one thing with that is, how to balance efficacy with first-line EGFR targeted combinations. We know that both FLAURA2 and MARIPOSA, of course, come with more side effects. How do you have that discussion? Do you discuss all 3 regimens or the 2 combination regimens and have patients choose, or do you guys have a specific one that you prefer?
No, I think that it's important to tell the patient, inform them, and have a discussion, even though now it makes a much longer discussion, that these are the options out there. Patients are, many times, I would say most times, they would like our opinion. And then I will tell them that I do prefer FLAURA2 because the chemotherapy, even though it adds toxicity, is a much more predictable kind of toxicity. We, have very good experience as oncologists managing it. But of course, there are patients who are very driven to avoid chemotherapy. So I think it's very important that we have the full discussion. And I believe that if my preference is asked, then I do tell the patient, like, why do I think, what I think.
Heather, any?
I think it really is about the balanced discussion. I certainly talk with any of my patients generally diagnosed about all 3 options. I know one of these questions about the CNS activity. I think that both options, both combination options, have better CNS efficacy than single-agent osimertinib, but single-agent osimertinib also has good CNS efficacy. So it's a really great place to be compared to where we've been at some times in the past. I think that we know that pemetrexed-based regimens work in the brain. I think there's data that amivantamab does work in the brain, and I think that both of the TKIs are equally, or at least the data that I've seen, they seem to be very similarly CNS penetrant and active. And so I don't know that that really helps me making a decision, other than if someone has CNS metastases, I'm certainly not going to go with single-agent osimertinib. And then as far as the others, it's about kind of talking through the toxicities and what's they're most afraid of. And obviously, if I know up front that there's MET overexpression, that might lean me in one direction, right? So there are a lot of different things that go into that. It becomes very individualized.
How much does, coming into clinic and chair time and medicalization play a role for your patients? And do you think that the sub-Q amivantamab will make a difference?
It's really interesting in talking with many people. We talked to a group of folks who were in community practice, and you say, which one would you prefer, like right now, if this was 6 months ago, right? And most people would say, well, I would go with FLAURA2, right? I'm familiar with that. And then you say, well, what if you could give sub-Q ami? And many people say, well, then I would go with MARIPOSA regimen. But then when you kind of push on that and like, well, the patients are still having to come in every couple of weeks, and it's not like a quick shot and then they're gone. It's a little bit longer, and they're still taking up some chair time and, nurse time. And, it's the decisions go back and forth a little bit more. We don't yet have access to sub-Q, where it's just formulary issues and, we're getting to it. So I don't know if things will change much once that happens.
Curious about in the community,
Yeah.
if that makes a difference.
Yes, so the sub-Q will take away the pain of the infusion and the long hours, but the dermatologic side effects are still there. The VT prophylaxis need is still there. So it is still a more intensive regimen to sign up on. So I think that sub-Q is great, but it doesn't, it's not a game changer, but certainly it's a big step forward.
Agree. Okay, so this is that same slide that Heather showed, introducing immunotherapy. I think, 20 years ago since, EGFR mutations were identified, and really we've gone through now several generations of EGFR TKIs, and really in the last 2 years, it's been, with the two combinations, it's complicated, and sequencing, really is very nuanced and patient-specific now. So our historical gold standard, of course, is the FLORA, a single-agent osimertinib study. So this, of course, demonstrated clear PFS and OS benefit compared to earlier generation TKI. So I think at a minimum for monotherapy, this is our gold standard. And as we all know, it's well tolerated, and we know how to manage the few toxicities there are. And then, we initially had data for PFS only for FLORA-2, which, showed hazard ratio of 0.62, about 9-month improvement in PFS with the addition of chemotherapy. And then more recently, we saw the OS data. And so this is more finalized data with a hazard ratio of 0.77. And I think it's been challenging in EGFR mutant lung cancer to show a survival benefit for different therapies. And so it was really nice to see, compared to the sequence where, of course, we give osimertinib and then give chemotherapy second line, to see, a clear survival benefit with the combination up front. And this is, kind of speaks to giving our best treatments first, right? I think we all kind of don't remember, we think all of our patients are, stay alive to receive all the different treatments, but that drop off, right, from between first and second line really is significant. So wanting to really harness the best, most effective therapies in that first line setting. And then very similar data, right? I think with Mariposa, I think the efficacy is actually strikingly similar with amivantamab and lazertinib compared to osimertinib. Again, we saw the PFS data and then the OS data, which was a little more, I think we're waiting to see more mature data for this. But again, the data hazard ratio is 0.75, so actually, quite comparable, the two regimens from an efficacy standpoint. So what are the clinical factors driving selection of the right treatment for the right patient? And so this, we've seen a lot of data for both FLORA-2 and Mariposa, really talking about these risk factors. And I think there's a real question of, prognostic risk factors versus predictive, right? I think we know and we have a sense that all of these are poor prognostic factors, right? And so things that have come up and really been looked at for both studies is CNS metastases. This is a very high-risk population. About a third, in our data, a quarter to a third of patients have a baseline at diagnosis CNS metastases or involvement, and then more than half ultimately will develop CNS metastases. So understanding if there's a differential between these different regimens in CNS control is really important. Liver metastases is also just kind of, visceral involvement, bulky disease, bone metastases. And then, we've looked a lot at EGFR mutation subtype. We're not going to talk about atypicals, but that is really a big area where, our current therapies are quite limited. And then, ctDNA, and then co-mutations like P53 and RB. And so I think that what this shows is these are all, that it's important that, we'll see this data for FLORA-2, but also for Mariposa, that these are, that even with these high-risk factors or without them, the benefit of escalation of therapy is pretty consistent with all of these different risk factors. And so I think important to think about these. Just again, to highlight CNS metastases, I think, as Heather mentioned, pemetrexed is active in the CNS. We know osimertinib is, but really to see that, better hazard ratio, the 0.72 for patients with CNS metastases, I think is convincing that escalation of therapy for that patient population is really important. L858R and exon 19 deletion, I guess one question to ask is, the panel, do you use exon 19 deletion or L858R to distinguish treatment? Do you treat them differently or the same, Heather?
When a patient has the L858R, I do talk with them about the fact that their prognosis might be, they might not have as long of a term benefit as they, sometimes happens. And so that's when I'm much less likely to give single agent osimertinib to. As far as choosing between which combination regimen, it doesn't really help. I think in both of them we saw benefit.
Deepti.
Yeah, I agree that it argues against using monotherapy, but you do need a combination if you see L858R.
And then I think a practical clinical question, which there isn't the data for, but what do you do for an atypical first line?
So I still think about afatinib in the atypicals. I think the amivantamab lazertinib data in the atypicals was also intriguing. But then it's a question about the toxicities. I think afatinib can be pretty rough also, and so I have started thinking about that more. I mean, obviously there are newer agents that are coming, and so clearly we think about trials when we can.
Deepti, how do you manage?
Yeah, I think clinical trials when we can is the first choice, but afatinib dose reduced is 20-30 milligram is typically tolerable. Amylase, of course, is an option now, but a more toxic one.
And I have put the ECOG Akron trial.
Good.
Yes, double dose OC.
Osimertinib, bevacizumab, yep. Okay. And then we've seen similar data, as Heather said. I mean, I think both the combination regimens are good for patients with CNS metastases. All of these drugs thankfully penetrate the CNS, so also, benefit for amylaser in this setting as well. And then, very similar risk factors, right, in terms of baseline ctDNA, lack of ctDNA clearance. Again, these are poor prognostic factors, but again, we still see the benefit of combination over osimertinib. So I think it really is an opt-out situation now, but the more of these risk factors that someone has, the more we're going to be pushing to say, really, if why don't we try the combination up front for you? Okay, so balancing benefits and risk. And then safety. I think that FLAURA2, we really didn't see any unexpected side effects, in terms of any synergistic issues. There are additive, of course, toxicity. We all know cytopenias with chemotherapy and the similar kind of EGFR-directed side effects that we see with osimertinib. But I think very manageable for patients. And then I think this data was interesting too in terms of exposure and kind of timing of TKIs. I thought, Ross Camage's lecture earlier today was really important about understanding not just severity, but also kind of understanding the cadence over time is so important for our patients. And so, I think seeing the different toxicities and when they emerge really is interesting. And then I thought the data in terms of duration of exposure was very interesting too. We wanted to know, does it matter how long the pemetrexed and the carboplatin, or particularly the pemetrexed, is utilized, and knowing that the median duration was 8.3 months. So asking my panel, so do you try to keep the pemetrexed going until progression? Is there a sort of a landmark time that you want to say, let's try to get to X amount of time? How do you manage that?
Yeah, I try to follow the trial as close as possible.
Yeah.
But yeah, I think the 8.3 months that they did in the trial, about that time, either the patient is very tired of having to come to infusion or starting to get some real side effects, so we end up dropping it. But to the extent possible, I try to keep it going.
I do the same. I mean, I'll do the lower the dose, go to 4 weeks, all the different things we do when we're not giving it with osimertinib. But if a patient's like, I'm done, I'm much more comfortable stopping it at that point. But I've heard where people will only give the induction and then stop, and I don't think that's the right message we should be taking home. I think that there is some importance to that continuation, but the duration, there's just no way to answer it because it wasn't randomized. So you can look at it a lot of different ways.
Yeah, I agree. And I do think that it is important to note that there are cumulative toxicities with pemetrexed that I think are underappreciated in studies, right?
Yeah.
We all see kind of edema and then the renal dysfunction, right?
Yeah.
I think that creeps up over time too, and is, especially for patients who are going to have longevity and be on different treatments, having that creatinine clearance decrease really is impactful for future treatments. Okay, so Mariposa 2, I think, understanding, this is, I guess the main things about the combination is, due to mention the VTE prophylaxis and the need for anticoagulation to prevent that. And I think when the anticoagulation is started, that was extremely effective in preventing VTE. And then it really is the EGFR and MET toxicities, which we know because we use amivantamab in other settings as well with exon 20. And these, I think the next one is exactly the onset, right? I think these are obviously front-loaded and come over, sort of most intense over the initial period, and then do get sort of attenuated or mitigated over time. And then I think this is really important, and I think Mariposa did not have a lot of the prophylaxis regimens that we now know are helpful. So thinking about Cocoon, I think it's intensive, but I think if you do that intense dermatologic prophylaxis, antibiotics, topical, emollients and things like that, it really does decrease the dermatologic AEs. And then, Skipper in terms of preventing immune-related reactions, of course, the anticoagulation, and then, sub-Q, right? That has been huge for, or will be huge when we think about decreasing immune-related toxicities. So do you get, when you think about amivantamab and lazertinib, do you guys discuss all of this at that first visit?
Yes.
Yeah. Okay. And then again, Paloma 3, I think interesting, I think we think of, there are a lot of drugs that are moving from IV to sub-Q, and, I think we think of them as equivalent, but interesting to think about potential benefits. So, there was this intriguing potential OS benefit with the subcutaneous, and so I think, I assume that all patients on amivantamab ultimately will go to sub-Q for many different reasons. And then what's next? I think, I've been talking with a lot of people. I think sequencing becomes complicated, right? Because depending on what people get first line, then that affects second line treatment options. And now we have ADCs that are coming along as well. I think some of the studies that are interesting are thinking about, tailoring treatment, right? Sort of being patient specific in terms of, what are high-risk features like, tumor suppressors and kind of escalating treatment for them. I think MET amplification, potentially, or MET overexpression as a biomarker, potentially for MET-directed therapy, whether it be savolitinib or amylaser, I think is interesting. And then should we move ADCs up to the earlier line setting? I think we didn't talk about this with non-oncogene altered cancers, but I think there's a real push to do that. And I guess one question to ask the panel is, do you think that these ADCs are going to be moved earlier, or do you think their place really is in the second line and beyond setting?
I think that, they will be tried earlier. Whether they will be a success, of course, we'll only find out later. But I think, of course, those trials are already in the works and many being planned.
And I'm sorry, I realized Heather just showed me the time, so let's just fly through this because we want to get you guys out. So this is a patient that has a 3-centimeter tumor, mediastinal lymph nodes, does have bone and liver metastases, has brain metastases as well. So, we're giving you all the high-risk features. Biomarker testing shows L858R. What would we do for this patient? And here are the different options. I promise this is, I think, the last question, but please answer. Okay, we'll end it. I think that, I think, I'm not sure is an answer, but it looks like most people Flora2 and then some amylaser. I think with these high-risk features, we're pushing you towards combination therapy. So let's move on real quick. It's okay. And I think it's similar. We're talking about if they're symptomatic, but if asymptomatic, small disease volume, no brain metastases, of course, that's someone that maybe you would consider TKI monotherapy and then, other high-risk features. You could answer this poll, but I know that we want to wrap up. I think all of these are important questions, and, I think, even with all of this great data, there are, gray areas where we have to use our judgment, but it's exciting to have all of this data, and we will stick around here if people have questions, but I think we're going to end it and let you guys go home and get to sleep. So thank you so much for sticking around. We really appreciate it, and again, we're happy to stick around and answer any questions. Thank you.
Are there any more slides?
The what? Is there one more we should
I
do?
don't know. Yes.
If you could do this one last.
Yes.
One. Thank you, guys. That was a lot to get through. Thank you for showing me that.
And we're here, so come ask us questions.
Yeah. Okay to go to sleep too.
Just a question. I think I sent a question. Would you do whole exome genomic testing?
Whole exome?
Yeah, just like over 20,000 genes.
I'm not doing that right now. I think that it's hard to know what to do with a lot of the data. We'll get there.
Okay. So when we try to do, would the TMB different, or also we try to do the panel versus doesn't work. Hello. I try to compare the new antigen detection rate. It's okay. I can. We can only detect 1 or 2 new antigens with a panel of 400, 600, or like 1,300.
Yeah. I mean, I think you're getting.
Yeah. So, I know the whole exon 20,000 gene, most of them we don't have, TKI for that. We know like 10 or 12 genes we have drug. But the whole exon testing, the one like we're doing, we try to see the new antigen detection from the panel. We find out that we can only identify 1 or 2 immunogenic new antigen, but we go to 20,000. Often we can find 5, 10, 20 new antigens that we actually try to generate immunogenic peptide. So I'm trying to do for everybody doing whole exome testing. I know it's expensive, but besides TMB or new antigen vaccine, preparation for the trial, would you trust this testing? Because is it deep enough? What I meant, if I go to so much wider, so many more genes, I'm losing the sensitivity for detect the most valuable things. So do you have any concern of doing more than that,
I think that, as Deepti said, I think we have trouble with just getting NGS testing on everyone. So I think it's really, you're speaking to other biomarkers for immunotherapy, right? I think it's super interesting, not prime time as of yet, but I think maybe we'll get there.
It's money because the insurance company issue.
Yeah.
So in China, actually, all patients themselves pay for that.
Wow.
From their own pocket. The medical insurance doesn't cover.
Yeah.
So if we do 20,000 gene plus like a CDA for 6 kinds of testing, it's equal to. It's actually very cost effective considering every of them. It's a package. They pay from their pocket. I'm trying to negotiate it. This one is cost effective because.
I think someday we'll be doing more of that, but I think we still don't know what to do with so much of that information, so.
Too much?
I think we just don't know what to do with most of it yet, right? Even with the neoantigens, we don't really have enough, so, yeah.
Oh, and then,
all right.
if
And we've got okay. So thanks, and I think we are going to do one quick closing for everybody. And that is just to remind everybody to please scan this code and visit peerview.com lungcancer26/ARS to claim your credit and access the activity materials. And stay tuned for online activity based on this event. So thank you all. And again, we're happy to answer some other questions, but